Surfing the MASH Tsunami brings you three major stories from the world of steatotic liver disease. This weekend, we're bringing you each of these stories separately so you can listen over a shorter, discrete period of time. Hope you enjoy them.
For the last 5 years, MASLD stakeholders, whether manufacturers, trial sites, providers, payers, patients, or investors, have turned to surfing the MASH tsunami to keep track of drug and device development, epidemiology, public health initiatives, and practice patterns. This weekend, we are sharing the three main sections from our episode 5. Roger will provide more information after these notes from our sponsors.
Surfing the MASH Tsunami is sponsored by these healthcare-related organizations, LiverRight and the LiverRight Scanning Network. On April 15th, 2025, LiverRight will open America's first virtual specialty clinic for liver disease, offering adults in all 50 states video appointments and helping GI practices and health systems triage and treat the swelling numbers of patients seeking MASLD and MASH testing. LiverRight offers same-week video visits and accepts insurance. For more information, contact LiverRight, that's liver, and then RIGHT at www.liverright.com.
Tawazin Health, your partner in global liver health innovation. At Tawazin Health, we specialize in providing small or large-scale access to FibroScan examinations for liver health-focused early detection, clinical trials, independent research, and collaborative projects with clinicians and FibroScan providers increasingly throughout the world. As industry-leading experts, we design and deliver high-quality FibroScan services because we know that accurate, high-quality, reliable data drives better outcomes. To learn about our sister lifestyle app, mylife365.me, click the Tawazin Health link on the Surfing MASH homepage. And now, here are Roger and Naga Chalasani with this week's Newsmaker segment.
Our Newsmaker interview this week is with Dr. Naga Chalasani from the University of Indiana. Dr. Chalasani and his group recently put a paper in Hepatology Communications discussing their early experiences with Resmetirom prescribing, which have generally been successful. He reports in our talk that of 114 patients for whom they first prescribed, 113 of those prescriptions were successful, and of the 80-something patients that actually went on the medication, 6 were able to continue, 6 discontinued, most because of side effects. He also notes that that was with a strategy called prescribe and forget, where they wrote the prescription, let the patient go on their way. They believe that using a prescribe and follow-up strategy where they stay engaged with the patient while the patient considers side effects and deals with them, they should be able to get the discontinuation rate down close to this 5 or 6% rate that Madrigal has seen in his clinical trials. Dr. Chalasani describes the paper and the process in far better detail and more clearly than I can here, so you should just listen to it. After that, he goes on to talk about some other things about their practice. The idea that they have 45 minutes for an initial visit and 20 to 30 minutes for follow-up, which I suspect has something to do with their success. He doesn't think this would work if they were rushed to do 10-minute treatment, which other places might be. He also talks about the role that GLP-1s and other agents are playing today and might continue to play as we go forward in treatment of the disease. All in all, this is a refreshing, helpful, practical conversation, and I enjoyed having it with Dr. Chalasani. Look forward to having him on the podcast again. Today's Newsmaker conversation is with a new guest, Dr. Naga Chalasani of the University of Indiana. Naga, how are you this afternoon, sir?
I'm very good. How are you doing?
I'm doing okay. As everybody who listens to the podcast knows, I've got a touch of bronchitis, a touch of laryngitis, but we got through the major recording this morning, and I'm still here, so I guess I'm doing all right. Right after Resmetirom was approved, maybe a couple of months later, we did a episode with Michael Charlton, which was about what the very, very early experience was with prescribing Resmetirom. At that point in time, he had maybe a dozen patients on it. I was talking about how it was going through his system. Well, so it's almost a year later. Michael is now working at Madrigal Pharmaceuticals, and Naga and some of his colleagues published an article in Hepatology Communications that went online last week about the first 6 months of their experience with Resmetirom. That's what we're going to talk about today, but before we get started, do me a favor, tell our audience a little bit about yourself and your background.
Yeah, nice to be on this podcast. My name is Naga Chalasani. I'm a hepatologist, and I practice, and I'm a researcher in the field of MASLD, MASH, going back to 25 years or so. I've been part of the national CRN, been heavily involved in the Resmetirom development program, and we've been very interested in the thyroid axis in MASLD MASH going back to 2000. And we're just pleased that our early experience was published in Hepatology Communications not too long ago.
And then can you tell folks one more thing about yourself that they might not know if you didn't tell them, something a little different or surprising.
I am very much into fitness, and last summer I did the El Camino walk from Lugo to Compostela, Santiago de Compostela, and in about a month's time I'm doing the Italian Camino via Francigena from Tuscany for about 80 miles or so. That's sort of been exciting to me, these walking, hiking pilgrimages.
And over how many days will you be doing the 80-mile hike?
Approximately about 6.5 days of walking.
Okay. So that's quite a bit of walking a day, right? And the one in Spain was also about the same length?
Yeah.
Okay. How many Caminos are there besides Spain and Italy, for those who don't know, like me?
I mean, the two main ones, one is the Camino de Santiago. That's the whole thing is about 500 miles. Mm-hmm. We've only done the last part of it. And then the other Camino starts in Canterbury, UK to Rome. I understand that's about 3,000 miles.
Wow.
We're only doing a small part of it in Italy. The Italian one goes to Rome, whereas the one in Spain goes to Santiago, St. James Cathedral in Santiago.
Okay. Now, do you plan to do more parts of this route in future years?
You know what I'd like to do is, go back to Camino Santiago in Spain and do twice the distance. And I think there's a place you can start called Leon. And that's about 180 miles, and you can probably do in about 15 to 18 days. That's my goal. It's really transforming just to be able to day in and day out do these long walks, and you meet people from all over. That's, to me, it's been incredibly satisfying.
It sounds like a fantastic thing to do. Our engineer right now spent the weekend 4 or 5 day weekend doing the first part of a 270-mile trek through the Ozark Hills in Arkansas. It's broken into 11 stages of about 25 miles each.
Yeah, that's brilliant. I just think it's, somebody asked me halfway through Camino last year, what's your experience? And it's the freedom. It just feels so free. And then for your audience, I'll say one thing. I did that by myself, did not go with my spouse. And then my spouse had done the same about 2 years before what I had done. So there is freedom that, going by yourself. If you're going to do these 80 miles, and at least to me, just seems pretty liberating.
Fantastic. So that is the first time we've had somebody doing this kind of distance walking come on as a guest. We're up at about 150 different guests over time right now. So every time someone comes up with something that's truly unique, I'm delighted. Thank you very much for that. And with that, let's go to the article. For those who don't know and haven't seen notes on this yet, the article, Early Experience with Resmetirom to Treat Metabolic Dysfunction Associated Steatohepatitis with Fibrosis in a Real-World Setting. And that appeared, I want to say end of March maybe, or right at the beginning of April. Why did you and the team decide to put this particular article together? What motivated you to do it?
It seemed like we rapidly accumulated a fair bit of experience. We were hearing from Madrigal team that we are one of the larger prescribers in the country. And for those who aren't familiar with how Indiana is set up, we're the only liver transplant program, only hepatology program in the state of Indiana. So we have very large hepatology practice. And of course, we've been in the NASH space, and we have a number of patients who've been eagerly waiting for an approved therapy. So we accumulated this 100 plus patients very rapidly. And then that's one we wanted to share. Second is, since this medication is only available through selected pharmacies, we have set up processes that turned out to be quite effective for us. So we wanted to share how we have set up. When Madrigal team members would come and visit us, they would from time to time would ask us, would you be able to talk to providers in Michigan or providers in Arkansas to see how we set that up? So we thought instead of talking to so many people, we thought we would just publish so people can actually have access to the mechanics of from the time we write a prescription to the time a patient gets their supply in mail. What are the steps involved? That's the second thing. Third, sort of came later on. As we were putting the data together, we understood that how we set up the care pathway at our own system needed to be tweaked. And I'll just elaborate more on it, as the discussion goes on. So multiple reasons, those are sort of the primary reasons that we put the paper together and chose to publish.
So what was the specific goal of the paper or the objective that you were writing towards when you wrote it? What were we measuring?
Just really early experience with patient selection, care pathway, how we got the medicine to our patients, and just to describe the safety tolerability. Those are sort of the three main goals.
And by that standard, the prescription pathway worked effectively. About 1 in 6 discontinued, and you thought that you wrote in the conclusion to the abstract, at least, that might be mitigated somewhat if you paid more attention to the patients.
Yes. So the practice has about 10 plus clinical hepatologists and about 6 or so prescribing extenders, really fantastic, well-trained part of our group. We all are writing prescriptions. So we have set up a process. The senior author of the paper, Dr. Samala, sort of championed this setting up the care pathway. We had a champion pharmacist who took upon themselves to serve as the pivot, to receive the referrals, to put the material together to the payers, and then to the pharmacy, the whole process. One of the things, take-home messages is if you are a high-volume prescriber where you have multiple providers, having a single source who administers is really critical. There are 2 ways to do it. So we chose an approach of a diverse pool of providers going through a single pharmacist. And there are practices where instead of single pharmacist, they have diverse group of hepatologists sending to one hepatologist. That way, one hepatologist sees and decides if the resmetirom is the right treatment and the dose and so on and so forth. We chose that we wanted to keep a plan where hepatologists are still seeing their patients and the pharmacists are just helping with getting the drug approved and dispensed. And for us, I think when we put the paper together, this was in December, I think we had something like 114 patients we prescribed. 113 were approved by the payers. Some haven't started, some decided not to go on for a variety of reasons. At the same time, we had some clinical trials. They wanted to go into clinical trials for weight loss and so forth. Well, the way we set up worked quite beautifully for us.
So why did you choose to set it up that way as compared to setting it up through physician? First of all, what is the benefit of setting it up with one central person being a decision point? And then why did you select to do it with a pharmacist as compared to the physician specifically?
I just think that one, though, is we collectively believed all of us are well-versed with treating MASH, and they all could make the right decision in terms of choosing resmetirom as therapy and then also the dose. We felt like they are we all were collectively comfortable. We all can do it. And then also we have at least 2 sessions. When the package insert came, we went through line by line of package insert. And then we have come to sort of an internal consensus, what kinds of patients we wanted to treat and how we would like to do first year, followed by, once we have enough experience, what we would do subsequent year. So that helped us. So we felt like we didn't need to consolidate all referrals into one hepatologist. Yeah, I think we would do it all over again because I think it's just a very well-informed hepatologist and the extenders.
So you did that. You wrote maybe 113, 114 prescriptions, virtually all of which went through. Yeah.
Except for one.
Okay.
All of them.
What was the key to all of them going through? Is there anything that people can learn about that?
Multiple things, though. One, I think all providers were on the same page because we went through as a group the package insert. We've discussed what kinds of patients we wanted to treat. So there was a general agreement. That's one. Number 2, I think the information that we were sending to the single source of truth, our pharmacist, was relatively consistent. And I would say our pharmacist was and is fantastic in terms of understood. This pharmacist has been with us going back to the direct-acting antiviral agents, the Hep C days. So you understood how this is done. It's not like the first time they were doing it. And then, of course, Madrigal has been very engaged helping the pharmacist. I think in a number of instances where we had to go back the first time, about 70% or so the first time went through, then we had to appeal again. And then if the appeal was turned down, always Madrigal was ready to step up and pick up, at least for first year, pick up the prescription. I can't remember how many we had. Also, the copay has been somehow managed with the vouchers and so forth. So I would say having partnership with Resmetirom, we work closely with them. They had absolutely no say in how, who we treated. But when we needed help, they were there to help us to set up the care pathway.
Basically, they took all the economics out of the equation, right, if I understand correctly. patient was not approved by the insurer, they still would get the medication free of charge or deeply discounted charge?
I think so. I think if after 2 attempts, if the payer did not pay, my understanding is that Resmetirom covered, plus as well as the copay was somehow covered through vouchers. So overall, I think they've been good partners.
So then all the patients were covered. If I remember from the article correctly, of the 110 that you wrote about in the article, 83 actually went on the medication within 30 days?
Yeah.
Was there a reason that people didn't go on the medication that's worth mentioning?
Some I think in transit, Roger. Some I think they just had it. They haven't quite started. There isn't anything. I think some of this is when you have these early experience papers, you always have these transitions. Unlike a clinical trial where you have a data cutoff and you have a data hold type stuff. So yeah, there isn't anything. It is just the mechanics of how these things work.
What's the experience been on the drug?
The way we set up the follow-up, which we have since changed, once the patient gets the drug, the medication at home, we set up the first set of labs at 3 months and a visit with their provider in 6 months. And what I describe as prescribe and forget approach. This is how we've done with DAAs for Hep C because, they were so well tolerated. We would prescribe, they would take it for 2 months, then we had the lab draws and they come back and see us 6 months cured. So we just sort of replicated that, but we realized with this medication that prescribe and forget isn't the right approach. You needed to prescribe and follow, meaning some sort of a follow-up, even a phone call at 4 weeks. I think it's more important, less about the labs, but I would think if a phone call at first month and maybe at 3 months, so patients know if they have nausea or diarrhea, abdominal symptoms, you're talking to them, adjusting the dose if so needed. So that's our experience, and I think care pathway we put in wasn't quite right for this drug, at least for our population.
Okay, so when you say prescribe and forget, you literally mean no follow-up at all?
So any follow-up during that window, the way we set up is they get the medication. The first thing from our side is they go get labs in 3 months, and then they have a clinic visit in 6 months. Anything else had to be initiated by a patient rather than prescriptively from a provider. So we didn't forget them, but the burden we left up to patients. Some called. When they had side effects, they called and we managed them. But many times they took upon themselves to say, well, I'm going to stop it.
So what was the effect of going from that system to the new system with follow-up?
We went to a new system, I think, around the holiday season. I don't think we have seen follow-up. And then also we are trying to have all follow-ups come within a month to one single provider.
And what's the thinking behind that?
Just simply practicality. Just all of us are very busy clinic schedules. So we identified one individual to manage the post-treatment, and this individual had availability on template, and we trained and just sort of managing once we initiated the treatment.
So I know you have no data on this, but do you have any sense of what that will do to the discontinuation rate?
I hope that it'll go down to what we have seen in the trial, 5-6%. Just because you're closely monitoring, and also if somebody gets nausea, giving some, promethazine or dose reductions. We have some tricks, right? Medicine is an art, so we may be able to do some of those things. I'm hoping discontinuations from 16%, we hope to reduce it at least by 50% to under 8%, maybe 5-6%.
That's fascinating because one of the questions that I hear all the time, not from doctors, but elsewhere in my life, is, well, those clinical trials, they really underestimate the side effects, don't they? And what I hear you saying is that in this case, in your experience, just provide and forget. It wasn't that big a difference. 16% is not nothing, but it's not that much different in the scale of 100 patients than 5 or 6% is.
Yeah, but again, though, in the clinical trial, Maestro trial, I think is like discontinuation was under 5% for 100 milligrams. Here you got 16%, that's 3 times as high. That is high. But I think there is a way, though, for a medication like Resmetirom. It is expensive. Patients need it. I think at least we learned that we can do a better job. We have done a very good job in terms of patient selection, how we prescribe it, but that's the beauty of research. You look at your experience and you tweak it, so in the end, patients benefit.
So I think that covers pretty much what was in the paper. What else do you have to share about the experience you and your colleagues have had actually prescribing the drug?
I think an area that we've been careful is to avoid somehow this medication going to patients with cirrhosis, because the package insert label doesn't require a biopsy. So you are looking for presence or absence of cirrhosis based on NITs, your clinical assessment and, fibroscan and so forth. An area that we've been good I believe is with these NITs, and I think we pay attention to the liver stiffness, the platelet count, the albumin, and whether somebody is drinking excessively. So that's one that I think is really important to make sure you're not giving this to patients with cirrhosis, because this is still, the cirrhosis trial is ongoing, and especially if you go to Child's B, the pharmacokinetics of resmetirom may be different. So your audience, that's what I would urge, is to make sure that if they aren't a hepatologist, but if things don't quite line up for lack of cirrhosis, seeking a hepatologist opinion, even curbsiding them, I think would be good for patient care.
What steps did you take to ascertain who was drinking excessively?
We haven't quite gone on to PET testing on everybody yet. It's just how ethically you tell the patients. So we are mostly self-reported basis, but we have experience. We've been in the alcohol-associated liver disease research for a couple of decades. So we believe collectively we can get the history of alcohol consumption in a non-threatening way, in a non-accusatory way. So I think it's largely self-reporting. Still you're going to have some patients who under-report, but we have not gone to PET, certainly not ethyl triglycoluronide in the urine in this population. We do in the transplant setting. And we have not consistently gone to audit, and I think we're discussing recently about doing on every patient an audit every year.
Okay, so you say we've been doing this a long time, so patients tell us what they tell us, but we have a sense of when that's right and when that's not. What could a listener take away from this conversation about how to determine that better?
You may not get all the details the first visit, Roger. You need to establish a trusting relationship. Once you have a trusting relationship, and I'm just saying in my 25 years of practice, maybe just a handful of instances, after repeated questioning, patients were not forthcoming. They always do. They understand. The first time it is, you just don't have a relationship. So doesn't mean they don't underreport. They do. But I think, at least the place where we practice, generally speaking, when we have a trusting relationship with our patients, they are forthcoming, and we have not been misled.
Sounds fantastic. And how long are your average visits, by the way?
A new patient, good 45 minutes, Roger. The second visit, we probably do 30 minutes. This is the second time. When people are coming every 6 months, patients with cirrhosis, I see them every 4 to 6 months. And patients with non-cirrhotic, 8 months to 10 months time range. And follow-ups, where I know their history very well, including their family and everything, I would say 20 minutes gives a really very satisfactory. Generally speaking, our rule of thumb is that patients, when they leave their doctor's offices, they just feel like they should be satisfied. They had their questions answered. We've been able to really accomplish that.
If you can get to 20 or 30 minutes, that's great. That's fantastic.
Yeah, I don't think we've ever been rushed to do 10 minutes. And you have mixture. Some patients only need 10 minutes, so you always sort of average this out. But our templates are 20 minutes though for follow-up. For new patients, it's 45 minutes, 40 to 45 minutes.
That's great. What else should I be asking you about this paper or about how you folks are treating that you believe colleagues listening to this podcast might want to, or drug companies for that matter, might want to understand?
I just think after a decade of negative results, and I think for MASH therapeutics, this seems like truly exciting. We have Resmetirom approved. We all have seen excellent results from the Essence trial with semaglutide. I'm sure you have that discussed. And then more recently, we have the results from the Symmetry trial with the FGF21 analogs. There's a lot of excitement. And still, I would say, though, paying attention to cardiovascular morbidity is really critical. Even in patients with MASH cirrhosis, stage 3 fibrosis, second most common cause of death is cardiovascular disease. So making sure their lipids are thoroughly managed. They're not smoking. Their diabetes is well controlled. So that's, treating the patients comprehensively is really important. I just can't emphasize enough about the management of lipids. They have dyslipidemia. Many patients walk around with an LDL 120 to 150. They have many primary care providers think if you keep LDL over 100, it's fine. But the problem is many of our patients have low HDL, so the LDL to HDL ratio isn't favorable. So just making sure that their LDL is low, they're adequately treated, their lipids are treated, and just get exercise, the muscle mass, and just the good medical care is really essential.
Interesting. Do your folks prescribe GLP-1s?
We do, but not the same way. We are not set up to do GLP-1s in liver clinics. We have a medically supervised weight loss program. So some of our patients go there and they have a program set up to prescribe and dispense GLP-1s.
Okay, so then in fact, the hepatologists do not prescribe, the bariatricians or whoever is in the obesity clinic too?
Yes.
Okay, great. Thanks. This has been fantastic. I look forward to having you back on and talking about other papers and broader issues. Have a great day.
Please join us again next week when we continue our roundtable on advances in drug development in the last year, and dedicate the rest of our episode to honoring the memory of Stephen Harrison on the first anniversary of his passing.
And until then, stay safe, surf on, and we'll see you next week on Surfing the MASH Tsunami. Bye-bye now.